for being here. The only thing I ask is that you keep that mic in front of you at all times so we can make a good record and we're all able to hear. Thank you. Counsel.
Thank you. If you could state your name for the record.
I'm Diane Allred.
What is your occupation?
I am a nurse practitioner at Holy Cross Mountain Point in Lehigh, Utah.
I'll get to your education and training in a moment, but first explain for the jury what is the difference between a nurse and a nurse practitioner.
So a registered nurse is someone who's trained to help with the care of the patients in a hospital. So they do the day-to-day medication administration, helping the patient in basically any way and during their care in the hospital. And that's what they're trained for.
How is that different than your role as a nurse practitioner?
As a nurse practitioner, I have had more education and I'm more trained to be more like a physician, actually. So they actually call us a mid-level, or nowadays they actually call us and physicians providers. So we're providers of the patient. So my role is more directed at as a physician, where I admit patients, I write orders, I'm ordering their medications, I'm ordering their fluid, I'm ordering their diet, and those kind of things. So I'm giving the instructions to care for the patient, and nurses follow out those cares.
Okay, so fair to say nurses often work at your direction to implement the orders that you've given on any particular patient.
Yes, correct.
I want to talk about your education. Briefly describe your educational path to your role now.
Okay. I started out many years ago as a LPN, and then I got my registered nurse, which is it can be a 2-year degree or a 4-year degree. I had to go back to school to get a 4-year degree, and then so that's a 4-year bachelor's degree in nursing.
And let me stop you there. I apologize. You mentioned LPN. What does that mean?
It's called a licensed professional nurse, and it's basically kind of the first step. They don't have a lot of them anymore, but years ago it was kind of like it was just a little bit lower than a registered nurse. You couldn't give like IV medications. So there's some limitations on it. So a lot of people, they used to kind of do that as the first step, and then a registered nurse. And then to be a nurse practitioner, you have to have a bachelor's in nursing, and then you go to 2 more years to get a master's degree in nurse practitioner.
Okay. And how long have you, maybe you've already said, and I'm sorry if I'm asking you to repeat it, how long have you been a nurse practitioner?
I graduated in 2013. So 12. Right? Yeah.
And you already stated what facility employs you, Holy Cross?
Holy Cross Mountain Point.
And what city is that located in?
It's in Lehigh.
Were you working in that capacity on August 12th through the 15th of 2024?
Yes.
Do you recall a patient named Kacee Terry?
Yes.
Did you treat her during the time frame I just said, the August 12th through the 15th of 24?
Yes.
I want to explain, because obviously we're talking about multiple days, and we'll get to the different roles and people that were involved in her treatment. And I guess, yeah, we'll start specifically with her. Explain how the tasks or specific parts of her treatment are divided among nurses, nurse practitioners, and doctors.
Okay. Just in general, or her?
Well, yeah, let's start in general, and then we'll go to her.
Okay. Generally, a patient is brought to the emergency room by family, by ambulance. Emergency room does an initial workup of whatever their issues are, their complaints. At some point, they decide whether the patient is sick enough to be admitted to the hospital or not, or discharged or whatever. And if they're admitted to the hospital, they call me and I go down and see the patient and evaluate, and then I write admit orders, and then the patient is brought up to the hospital, to the floor that I work. And then I write those orders for, just like, for example, their medications, their fluid, their whatever, oxygenation, any of their needs to support them and help them towards getting better.
And then how, and I understand this may vary based on the patient's condition, at what point do doctors or physicians get involved?
I have a physician that I work with that is kind of over me every day, and we work together. And so sometimes those physicians are in other, around, like actually they can be at a different hospital working, and I'm at the hospital. So I contacted them, I talked to them, the physicians, we basically work together to provide the care and for the patients, yeah.
Fair to say that physicians, nurse practitioners like yourself, and nurses kind of all work as a team to collaborate on determining what care is appropriate and then executing that care for any given patient.
Yes.
Were you assigned to Kacee's case for the duration of her stay?
Yes.
When that happens, when it's over multiple days, how does that work? What kind of hours are you working?
So the physician is on from 8 in the morning until 8 the next day. Every day there's a physician on, sometimes it's the same one for a few days. I work, at the time I was working, like my day shift was 8 to 4, and then at 4 o'clock until 8 the next day, it's either me or the doctor that is on call. So the doctor's always on call over me, does that make sense? But I would be first call if I'm the one that's on call that day. So the ER would call me first. Then I would put in orders. It allows us to each get sleep, potentially, so because we can cover for several days in a row. So.
How are the nurses involved in the team? Are they kind of scheduled similarly? Do they shift out more regularly? How does that work?
Nurses work 12 hours on, 12 hours off, so 12-hour day shift, and then a night 12-hour nurse will come on. So that's how they work. So they have their own kind of class, schedule that they come in, just do 12 hours a shift.
So you mentioned that it's important that you be able to go home and get some sleep at some point. Anything that happens while you're kind of off the clock but still on the case, how are you made aware of what happens during that time period?
If I'm not on call, I will go home, and most of the time I try to clear my brain of things and just kind of have a little bit of a life. But by the next day, I wake up early, and at 7 o'clock in the morning, I'm up looking at my patients, seeing if I have any new patients, to see what's changed, those kind of things. So I kind of keep up on it. If I'm working several days in a row, I will get on the computer and look up what's happening out of curiosity, and also just making sure I'm up. But by the doctors, let's say the doctor's been on call all night, I will get up in the morning before my shift starts and look at everything and just make sure that I'm back, caught up on what's happening.
Would you have done that same kind of protocol in Kacee's case?
Yes.
Do you recall how Kacee presented when she arrived?
When she came to the emergency room, I know that she was unresponsive. I know she was not communicating. She was not, she was breathing on her own, but it was very shallow, not sufficient breathing. And so I know that the ER had to give her some medication and intubate her to support her breathing. But she was not responding. She did have some pupillary response, but she was not withdrawing to pain. So one of the tests, if someone, we literally pinch your nail really, really hard, or rub your chest really, really hard, and that hurts. And so people will, even if they're not awake, alert, and oriented, they will, most of the time they will pull away, and she was not doing that.
And to be clear, were you actually present during this initial presentation, or is this just something that you learned later on that affected your treatment and care of her?
When she very first came on, I was not down in the ER. The ER was managing the initial things, but then shortly after, especially if we know it's going to be a patient that's going to be sick, that's going to be admitted to the ICU, I generally go down and see the patient and start doing, talking to the family and the ER doctor and getting everything set up to be able to, once she's stabilized in the ER, to get her back up into the ICU.
Okay. So did you actually go down and observe the symptoms that you're talking about with Kacee, that she was unconscious and very shallow breathing, and her pupillary responses, her pain responses?
Yes, I did.
At that time, did you know what had happened to her?
We know from the EMS report that when they got there, she was not breathing well on her own, not responsive. We call it altered or altered mental status. And we know that her blood sugar, EMS checked her blood sugar at home, and her blood sugar read too low for the monitor to read it. And so I know EMS had initially they started an IV with some sugar in it, some glucose, and then also, I think they gave her a little extra glucose at that time. So we knew her blood sugar was extremely low at the 14. Actually, I mean, in the ER, her first blood sugar check was 14.
Okay, we've heard, the jury has heard a little bit about blood sugar levels. Understanding this can vary among people, but what is a range of blood sugar levels that you would consider to be normal?
I think normal is 70 to 100, 90 or 100. I don't remember the exact numbers.
How low is 14?
14 is extremely low. Like, a person in that state is not awake, not alert. They're confused. If they have any, they can potentially still move, but they're not with it. They can't follow commands. It's really, really low.
At what point in the normal range that we're talking about would you expect to start a patient to start losing functionality or become confused or and then potentially not be conscious anymore?
I'm not sure. I do know that diabetics, when they start getting around 60, they will start to feel symptoms. They will get diaphoretic. They will start not thinking straight. They can feel that their blood sugar is going low, and they're like, okay, my blood sugar is dropping. I need to get some sugar in me now. I don't know what level would be where someone is more incapacitated than another. I don't really know an exact number. I've seen someone at 23 be very confused and not with it in the past, and some numbers like that.
Okay, so you mentioned that you're aware that EMS gave Kacee some sugars, even potentially on scene.
Yes, they did.
Do you know how that is administered?
They give it. They started an IV and gave her an intravenous drip, and then also I believe they gave her a bolus of insulin at that time also.
I think we all understand what an IV is, but what do you mean by IV drip?
Basically, that we have IV access when you start an IV, and we hang a bag of fluid that just drips right in at whatever rate we set it at, and it's continuous. Basically, in this situation, it would be a dextrose solution, sugar water.
And then I think you mentioned a bolus insulin.
Bolus.
Bolus insulin. What does that mean?
So bolus is like a one-time push of a medication. So we, for her, you would have it's actually a higher concentration. Whenever someone's blood sugar starts to get low, we give them, if they're awake still, we will give them something to eat or drink. If they're not quite awake, you can give them like glucose gel in their gums, and their body can absorb it that way if they're not quite able to swallow. But once they get really low, we have to just give it IV. So a bolus is just a push of a big dose of whatever you're giving.
You mentioned insulin. My understanding is insulin.
Did I say insulin? Oh, sorry.
No, yeah, so I wanted to see if I understood correctly. I might be wrong. I thought you said bolus insulin. What did you mean here?
I mean bolus of the dextrose.
Okay, and what is dextrose?
Dextrose is, glucose and dextrose are basically interchangeable. Dextrose is kind of that's the IV form that's manufactured and made. We call it dextrose. Glucose is your blood sugar level, and that's kind of like your glucose level, blood sugar level. Those are what we check, but it's sugar. So if I say dextrose and glucose, it's kind of interchangeable ones. Does that make sense? They're interchangeable words.
Let me make sure I'm understanding it. Glucose is maybe what you might refer to your body producing on its own, or what your own levels are. If something has to be given externally, you may call it dextrose. Is that correct? Okay. And you probably already answered this, what does dextrose do?
So dextrose is a concentration of sugar. There's different concentrations we give depending on what level how low their blood sugar is, and it's just a bolus of sugar water, dextrose.
And you mentioned that with Kacee, it was administered intravenously, is that correct?
Correct.
So her blood sugar level, you said, is extremely low, 14. What would you expect, I guess, if she's given an IV of dextrose? Would you expect her sugar levels to change dramatically quickly, or how might that look? What was your expectation?
Generally, most people, once you start getting their blood sugar level up, they start to become more alert as pretty quickly, believe it or not. So once you give this big a dose of sugar, it gets into their system, and they do wake up pretty quickly. I've had someone, my patient that I said her blood sugar was 23 and was very, very confused and altered and stuff. We gave her, that person dextrose, and as soon as she started getting around 50, 60, 70, she woke completely up.
Did that happen with Kacee?
No.
So at this point, her blood sugar has been tested by EMS, and she's at the ER, given an IV of dextrose, and she's not changing. What happens to her at that point? Have you come to admit her? I guess what's the status of her being a patient?
So at that point, because she wasn't breathing, we've now intubated her. We're put a breathing tube in for her, hooked her up to a ventilator to support her respiratory status, so now she's breathing. She had a continuous infusion of the dextrose going. Initially, it was they call it D10, so it's 10%. We changed it to D20 pretty quick. I can't remember how quick.
And let me pause you there. Why would that change have happened from D10 to D20?
Because we gave her so she's getting this baseline of sugar because her IV's got this continuous amount, and we're having to give extra sugar. And even if one time her blood sugar went back up, it continued to drop back down again with time. Like, it just didn't stay up like it would. She just had enough insulin in her that was basically causing her blood sugar to just drop again. So then we were checking it every 15 minutes, every 30 minutes for the first 2 days, basically, because it was just, we'd give her sugar and it would just drop again. We'd give her sugar, it would drop again.
Okay, so you were never able to stabilize her blood sugar?
Never.
You've mentioned insulin. We probably bored the jury a lot about educating them on insulin. Sounds like you're familiar with what insulin is. Again, not to belabor the point, generally in like one sentence, describe what insulin is.
Insulin is your body, actually your pancreas, the beta cells in your pancreas produce insulin. So you eat and you eat, your body takes that in and has glucose in it. And insulin is required your body will produce insulin to help the glucose get into the cells, and from the bloodstream into the cells. All of our cells need sugar. They all need to function. And so an insulin is, I kind of say it's kind of the key to the door. So insulin unlocks the door and lets the glucose in. And our body produces it on its own when normally.
Are there some people that don't produce insulin in their own body normally?
Yes, diabetics.
And we've heard a lot about their requirements so far, but generally briefly tell us what they require.
So there's a type 1 diabetic and a type 2 diabetic. Then you can actually become like they kind of call it a 1.5 diabetic. But a diabetic type 1 is where your body does not, your pancreas, your beta cells do not make insulin at all. And so you have to have IV from the minute you're diagnosed, you're on injections of insulin from the very beginning. Type 2 is the people that their pancreas is just not making enough. And so a lot of the times they're just on oral medications that just help their pancreas and their beta cells to produce more insulin. Eventually people can become insulin resistant, and so their body is just, or the pancreas just gets tired and kind of stops making it. And so a lot of type 2s can end up on insulin anyways, just because their pancreas kind of putters out.
Okay. You mentioned before that you were unable to stabilize Kacee's blood sugars ever during her stay at the hospital. I think you mentioned because she had so much insulin. How did you make that conclusion?
Insulin, there's a couple types of insulin. There's the fast-acting and the long-acting. If I eat something, and I know I need some insulin because I'm a diabetic, I can then calculate, give myself a little bit of insulin that's gonna help with just that meal, for example. So you do that basically every meal. You give yourself a little extra. With her, where she just kept dropping and dropping and dropping, she had enough insulin, and presumably the long-acting insulin, because it was days of us trying to get her glucose level controlled and back up to a normal range, and it took days, I mean, of just us giving her all this sugar. So in my opinion, I believe that she received a lot of insulin and a long-acting insulin.
Okay, and that's your opinion that it was long-acting. But is it fair to say, well, I guess, let me figure out how to ask this. How is insulin, if given exogenously, externally, if you get a shot, how does it disperse throughout the body, and how quickly does that work? Understanding that there's short-acting and long-acting, and those differ. But if we're seeing results of insulin 3 days later, I guess, how is that being processed by the body? Does that make sense?
Yeah, I'm not exactly sure, like the half-life of the medication. So every medication has kind of like a half-life and how long it lasts. If you take Tylenol, you can repeat that Tylenol in 4 hours, because they know that this is the half-life is X, and in 4 hours it's out of your system enough to take it again. So the fast-acting insulin, again, every meal they're taking it because it wears off quickly. Where the long-acting, I do not know what the half-life of long-acting insulin is, but it lasts. In fact, normally, for example, we give a shot of the long-acting generally once every 24 hours. So a diabetic that's on, and they want it to be this basal, they call it a basal amount of the long-acting, and then in every 24 hours, they give themselves another shot of the long-acting insulin.
Okay, and so Kacee was not able to be stabilized over 3 days, and so your conclusion is there's enough insulin on board that it's still affecting her body 3 days later.
Yes.
Was she continuously being given dextrose as part of the treatment plan over the 3 days?
I think she was given dextrose until they initiated hospice. I think she was still on the dextrose infusion that entire time until they chose to go on hospice and withdraw care.
And who makes that decision to go on hospice?
Family, doctors, basically.
And who makes the decision to withdraw care?
Same thing. I mean, it has to be the family decides. We help with those decisions. We don't make that decision at all. It is the power, whoever is the either power of attorney or next of kin can make that decision.
And that decision is presumably informed by doctors and your conclusion on their prognosis or whether they're going to get better.
Correct.
Did you determine, you and your team determined that Kacee was not going to wake up?
Yes.
Does insulin itself directly kill someone? Does that question make sense?
Yeah, I don't believe that insulin itself, it's the side effects that are caused from the insulin.
What do you mean by that?
For her, or for anybody, if you give insulin, that lowers your blood sugar level. If your blood sugar gets too low, then you get the signs of, you get hypoglycemic encephalopathy, which is basically low blood sugar, mental problems. She was not breathing appropriately, therefore she wasn't getting enough oxygen to her vital organs and her cells. Therefore, you end up getting a brain damage and multi-organ damage from the hypoglycemia caused from the insulin.
Okay, so if somebody's given insulin, their sugars are allowed to drop so low that they become hypoglycemic. That can also affect their oxygen and breathing?
Yes.
How does that work?
Basically, when you're confused and when your blood sugar is so low, your body is not functioning correctly, And so you are then not breathing for yourself appropriately. You're not breathing enough. The low blood sugar can cause the hypoxia also. And there's lots of things that can cause lack of oxygen. You can have a heart attack and your blood isn't pumping and you're not getting oxygen. But the hypoglycemia actually can cause this encephalopathy of the brain, along with and caused all from the insulin.
Encephalopathy, I don't even know if I'm pronouncing it correctly. What does that mean?
Just basically, it's the brain, so you're confused. It just means altered mental status. It's a medical term for being altered, confused.
Okay. You talked before about, and I forget the level, maybe you said something in the 20s. You had a patient that had low blood sugar. You got dextrose on board, and that patient picked up rather quickly. Do you remember that?
Yes, that one. Mm-hmm. I've had it happen many times.
Why would it be the case for Kacee that she didn't just pick up as soon as dextrose is given? She starts getting glucose and sugars and starts breathing and starts getting better. Why did that not happen? Time
is the issue with it. So the one patient that I was talking about that was 23, I had seen, she was a patient that I had seen that had seen like an hour before. So quickly went in there, confused, not acting normal, checked a blood sugar, gave them things. I've also seen a similar case where a patient also came into the emergency room. That patient was altered, ended up intubated, got sugar, got boluses, was cared for, but when we back off on sedation and we give them time, their blood sugar normalizes, and when we wake them up, they wake up. They start showing they'll even start showing signs where they'll start to move, or they'll start, sometimes they'll be still kind of asleep, but they can follow commands. You'll say, squeeze my hand, and they can still squeeze your hand. So we see signs that this person is improving, and then with continued support, continued care, eventually this person I'm talking about recovered. And so time is the amount. It's how long I call it their downtime. How long were they in this state of not breathing, not oxygenating, low blood sugars, all the changes chemically in the body that are happening because of that. So time is the teller.
And why does a longer amount of time make it harder for a patient to recover?
Because lack of oxygen and lack of breathing is what causes the damage to the brain.
And it sounds like that can be irreversible damage at a certain point.
Yes.
Do you have a particular hypoglycemic protocol? Somebody presents as hypoglycemic. Do you have something that a protocol you engage in?
We do.
Explain that for us.
Basically, we have a protocol in place that as we're checking people's blood sugar, if their blood sugar gets to it, it's almost like if it's this, you can give juice. If it's this, you do this. If it's below, once a diabetic is below 60 or 70, we do give them dextrose, IV push, because we can see that we're downtrending, and so that the nurses have a protocol. I order a protocol. It's very set in standard, and it's if you see this, do this. You see this, do this. You see this, do this.
And that would be based on physical symptoms, and then also the monitoring of what their current glucose level is?
Yes.
You mentioned that Kacee was given D10 first, and at some point it was up to D20. Do you know if that had to be upped further?
I think in the IV infusion, we only went up to the D20, but we were still giving her the extra sugar when her sugar would drop low, even with that steady dose. She still required multiple doses of extra sugar.
I think you described before that you were able to get sugars up and just not stabilize. So did her sugars ever rise to a level that was normal?
Yes, in fact, even I remember there's a blood sugar reading of like a 500, which would be really high, right? But it wasn't long, it didn't stay that. It just then, with just not even a long amount of time, it just comes right back down again. So there were times where her blood sugar would go up to 100, little over 100, and then we just keep taking it and watching it, and then it starts to dip again, gets below the parameters, we would give extra.
And I believe you stated that signifies to you that insulin is still operating in her system because her sugars are not stabilizing.
Yes.
Sounds like you're familiar with insulin. Do you treat diabetic patients?
Yes, every day.
What dosage would you typically order for a diabetic patient?
It really depends, because some people are, if they're a new diabetic, they're very sensitive to insulin, so you would give a lot smaller of doses. The longer they've been diabetic, they kind of tend to need more. And so sometimes I've given, 10 units of the long-acting once a day. Sometimes I've given 100 units a day.
Okay, and that would depend on the individual patient.
Correct.
You mentioned if they're a new diabetic, I guess someone who has never had insulin would probably require less. Is that fair?
Yes. If they're insulin naive, is what we call it, their body has not had insulin, exogenous insulin, then they would require much less.
What would you expect to happen to a non-diabetic person that's given insulin unnecessarily?
Extreme hypoglycemia, depending on how much they got.
What would you expect, just for example, if a non-diabetic is given 100 units, what would you expect that to look like?
Their blood sugar would drop to probably a critical low level. If it was the short acting, then it would hopefully rebound, depending on how low they got and those kind of things. If it's the long acting, it's going to stay down a lot longer, so they definitely need intervention.
I want to switch to a little bit of a different topic. Have you treated a patient who has attempted suicide by insulin before?
Yes.
And understanding that you can't give too many details about patients because of privacy issues, what did that patient do?
This patient came into the emergency room, very similar, was not breathing, had to be intubated.
Excuse me, Your Honor. May we approach?
All right, I'm going to switch gears. We talked before about how you work with basically a team. You work with physicians, doctors, nurse practitioners, and nurses. Is that fair?
Yes.
So to do your job correctly, do you have to have a pretty firm understanding of what nurses understand? Because you're giving them commands and orders and you're expecting them to follow through and follow your orders. Is that right?
Yes. I am a registered nurse, and I worked as a registered nurse for many, many years before I got my nurse practitioner.
And in your day-to-day as a nurse practitioner, is it important for you to understand what a nurse would know?
Yes.
So for example, would you expect a trained registered nurse to understand vital signs?
Yes.
Would you expect a trained nurse to understand what insulin would do to a non-diabetic patient?
Yes.
Would you expect a trained nurse to understand that continuously dropping extremely low blood sugar would require immediate intervention?
Yes.
We talked before, Kacee never regained consciousness.
No.
Did she die?
Yes.
Sounds like you have made a professional opinion that exogenous insulin was given to her at some point.
Yes.
In your professional opinion, if she had not been given insulin, would she have died?
No.
In your professional opinion, if intervention had happened earlier on Kacee, sugar's been given sooner, might you have expected a different outcome?
Yes.
I'm okay to pass the witness.
Shall I cross now, Sims?
Yes.
If I'm able, I might need your help. Good afternoon, Ms. Allred.
Afternoon.
I'm going to talk a bit more about some general conclusions from the treatment and role you had with Kacee Terry that night, okay?
Okay.
And maybe more than that. I say that because you ultimately spoke about things that happened in the hospital until the decision was made related to hospice, right?
Yes.
And then at that decision, no medical intervention is undertaken, right?
No life-saving medical comfort measures are continued until the patient passes.
Relevant to, I guess, your role in discussion here is nothing was done in connection with the attempt to deal with the insulin problem. No glucose would have been administered.
Yes, once they decide to place her on hospice and do comfort measures, we stop any blood pressure medication, supporting their blood pressure. We actually extubate them and take the breathing tube out, and all other, stop antibiotics if we're giving them and those kind of things. And we would, in this situation, stop the glucose.
You know, as you sit here when that decision was made,
I actually believe they switched her to hospice the evening of the 14th, but I'm not sure.
do you have records that would help you refresh your recollection that it could have been the morning of the 14th?
I don't remember.
Okay. If it was the morning of the 14th, that would be roughly, well, she went to the hospital around 10:30, is that right?
10:30 at night.
Yes, on
PM.
the 12th.
On the 12th.
So, we can count the hours. We don't know exact hour in the morning of the 14th. Let me leave that general question and go to the time component of what you were talking about when you talked about brain anoxia.
Oh, yes. You can.
Brain,
Yes.
is that the same
You can call
same
it-
circumstance?
Yes, you can call it anoxic brain injury.
Thank you. I'm sure Ms. Hunt is jealous. Anoxic brain injury, let's talk about that timing of that when you described it. It sounded to me like it's to avoid it in a circumstance such as this with the insulin overdose. To avoid it, you have to act on the glucose issue, right?
Yes.
So, and as you said, time is obviously important because if you don't act, the brain remains in this anoxic circumstance, right?
Yes,
And is being injured. That's the anoxic injury, correct?
yes, lack of oxygen.
The lack of oxygen to the brain, you had given an example, I think, of a patient who began to be critical, let's put it that way. I don't know if you knew about the anoxic brain, and who recovered because there was intervention within an hour, right?
The one that I was talking about when the blood sugar was 23,
Yeah.
that person, sorry, that was many, many years ago. She did not get anoxic brain injury.
Right, because, I mean, you even described that while she was pretty out of it, she was conscious.
Not able to swallow, like we still had to give her IV medication because she was totally confused, not able to follow commands. And so we had to intervene with IV to get her blood sugar up. Then we were able to have her drink and
Okay.
that kind of thing.
And then, but you got to start at 23, you knew it, she was in the hospital, I take it,
Yes,
and administered that care. She avoided risk of any anoxic brain injury, right?
yes.
Because she was, you could act immediately. Are there circumstances where a person has been in at a low glucose level for a period of time that you think that they would have no chance of recovery?
Yes,
How long? I mean, if the brain is anoxic, the chance of recovery, would you agree, could be as short as 1 hour?
I don't think that, well, okay, so
You understand my question? I'm sure I'm doing a poor job and you can help me in any
It's
way
okay.
you think. Okay.
in a normal person that has no oxygen to the brain, they say 4 minutes, right?
Right.
That's kind of the, start CPR fast because the brain can, without oxygen, can't live past 4 minutes. And that's without oxygen, right? So you're drowning, your heart isn't pumping, those kind of things. In this scenario, it takes longer than that because your brain is probably getting some oxygen, just not enough to perfuse the brain and all the cells it needs. And because it's not getting that amount that it needs, the brain gets injured. So time, again, is the downtime is what is important without intervention. Did I answer that right?
Sure, yes. Let's
Okay.
put a case specific here too. Is it your opinion that when Kacee Terry arrived at the hospital, given the circumstances of what you've seen, she never had a chance of recovery?
I didn't know that at the time because we always try, right?
Of course.
But she was not showing signs of, she was not on sedation at the time initially, right? She was not breathing well enough. She was not following commands. She was not even able to protect her airway to the point where we had to breathe for her and help her, breathe. So when anybody comes in, I don't automatically think, oh, we are gonna do everything we can to
I totally
help this
understand.
person.
I might have led us on the wrong path.
Okay,
I don't mean
sorry.
to suggest that you wouldn't try.
Oh, yeah.
Looking back, that's kind of the way you started. Looking back at the evidence you had as you sit here in your capacity, it's clear to you, isn't it, that Kacee Terry, when she arrived at the hospital, wasn't going to be someone who could recover?
I probably had the next morning. So when they intubated her, we gave her sedation medicine. So now we've sedated her. The next day, we do what's called a sedation vacation, where we turn off the sedation to see what kind of response we're going to get. And when that happened and she did not improve at all, that's probably when I get concerned. So actually later that day, I believe that's when we did the MRI later that day to evaluate to see if we could see that she had any brain injury.
And she did.
She did.
So you're not really able, in fairness, that you wouldn't know at what point in time exactly Kacee Terry was likely not going to recover from the injury to her brain caused by the glucose deficiency.
I don't know a number. I know that there are studies that show in insulin that 6 to 8 hours it's in studies.
Let's talk about the conclusions and things that you saw, base your conclusions on in terms of the introduction of the exogenous insulin to Kacee, to your patient that you saw. You concluded that based on everything, I'm not gonna make you go over it again, based on everything you did there, everything you did in the hospital that day and a half, that she had had exogenous insulin introduced to her,
Yes.
and that whatever had happened, you thought it was a lot, right?
Yes.
And you don't know what a lot means. In other words, I thought I heard you say different people react differently, especially if they're non-diabetic. And the notion is significant amount because of the vitals that you saw and the efforts that were done in the hospital.
I believe.
I mean, the point is you can't say a number of units or
There's
things like
there's
that.
no way to know a number of units because everybody's so different.
Everyone's so different, but so that's why I'm just getting at a lot. Something significant enough to do with cause the symptoms that you saw.
Yes.
That it could, you thought it included long-acting insulin.
Yes.
Could have also included short-acting insulin.
Yes.
Could have been injected subcutaneously.
Could have been.
Could have been injected, okay, and then let's go to timing.
Okay.
As you say, with the difference of the way people respond to it, the fact that long-acting and short-acting could be on board, could be administered, you don't really have any ways, you sit here today, to project at what time or times insulin was put into Kacee Terry's body. Is that fair?
Fair. And cannot tell.
It could even have been 24 hours before she reached the hospital, agreed?
With maybe, I mean, if long acting is given every 24 hours, but if it had been that long, she came into the hospital roughly 12 hours, so I don't think it could have been given the day before.
I'm just talking about that she comes in the hospital, I think you said 10:30, right?
Mhm.
Yes?
Yeah.
Sorry.
Yes.
And you've talked about what you think was done with insulin, long-acting, short-acting, maybe both, maybe multiple times. But at any rate, what you can't conclude is when those events of introduction of the insulin occurred, right? You can't conclude that.
I believe her last known well, according to my notes, was 9 o'clock in the morning. That's according to I don't remember who family said that or talked to her, they saw, I don't know, but in our notes it says that her last known well was 9 o'clock in the morning.
Okay, but become unwell, she could have even gotten insulin,
At 9
introduced the
o'clock in the
insulin
morning.
before 9, right? 8 o'clock.
Sure.
Thank you, that's all I have.
I don't have redirect. This witness may be excused.